And welcome to I-CBT Fridays. My name is Margaret McCall, and I will be the host of the meeting today. Today's presentation will be recorded. I would like to ask you to hold your questions until the end. You are also welcome to put your questions in the chat, and if time allows, we'll be asking from the chat as well. Today's presentation is by Frederick Aardema. Dr. Aardema is a clinical psychologist, researcher, and professor in the Department of Psychiatry and Addiction at the University of Montreal. He has dedicated nearly 3 decades advancing the understanding and treatment of obsessive-compulsive disorder, pioneering innovative approaches to help individuals overcome this disorder. As the co-creator of inference-based cognitive behavioral therapy, he is at the forefront of its ongoing development, validation, and dissemination, providing individuals with OCD a novel and highly effective evidence-based treatment option. His research focuses on reasoning, imagination, and feared self-perceptions in OCD, offering profound insights into how the disorder develops and persists. In his role as director of the Obsessive-Compulsive Disorder Clinical Study Center at the Montreal Mental Health University Institute Research Center, Dr. Aardema leads cutting-edge clinical trials that compare I-CBT with other approaches such as exposure and response prevention. Welcome, Dr. Aardema.
Thank you, Margaret, and good day, everyone. The purpose of the presentation today is to provide an introduction to inference-based cognitive behavioral therapy. It's a presentation I recently gave at a scientific conference in Italy, and I thought it would be well suited for our meetings here as well, especially with so many new members joining our group, many of whom were still relatively unfamiliar with the treatment approach. It's not a complete overview or a full training, which would require far more time, but more of a primer to bring everything together, including some of the latest ideas of the Resolving OCD book series. And in that sense, I hope it also offers something for the older members. We'll also post it on our YouTube channel as a resource for future members. You'll also probably will see me giving this presentation in other places over time as an introduction to I-CBT. These are some of the topics I'd like to cover today. Given the time, it can only be a bird's eye overview, but I hope it will give you a better sense of what I-CBT is about. I'll start off briefly with the origins of I-CBT and also touch on some of the clinical trials that have been carried out. But the main focus will be conceptual and clinical. In particular, I'll try to situate I-CBT within the broader landscape of OCD treatments and how it compares to other approaches. And from there, I'll discuss the actual model, its core principles, and how it reframes obsessional doubt, not as a fear to be managed, but as a product of reasoning and imagination. And to the extent time allows, I'll also briefly touch upon how these principles are applied in practice. And finally, I'll round things up with how I-CBT relates to ERP, because that's what it often seems to come down to, the tension between cognitive and behavioral approaches in the treatment of OCD. So as far as the origins, I-CBT has been around for 30 years already, starting in 1995, so not really new in those terms. These are some of the crucial time points of the first 10 years. It's an approach that was originally conceptualized by Kieran O'Connor and Sophie Robillard in a clinical and theoretical paper published in 1995. And in this paper, it was argued that OCD was characterized by distorted reasoning processes that could account for OCD, particularly among those with washing and checking compulsions. After this, there was the first empirical study on these reasoning processes as part of my master's thesis, together with Professor Paul Amelkamp. This was published in 1999 and showed that these distorted inference processes were one of the strongest predictors of obsessive-compulsive symptoms. And this was independent from obsessive beliefs and negative mood states, which we measured at the time with an item pool that later became known as the obsessive beliefs questionnaire. More papers followed. In 2002, a position paper came out that argued against the idea of viewing obsessions as intrusive thoughts, but that they are better conceptualized as inferences or conclusions. Then also in 2003, we wrote a paper expanding the model, including those with unacceptable thoughts and ultimately all forms of OCD. And finally, in 2005, the first book on I-CBT was published, Beyond Reasonable Doubt, which also included the first treatment manual. So this was the first 10 years. There were many more publications after this, but I don't want to go into detail on the research, except to just highlight here the most important clinical trials. These trials now add up to a total of around 700 participants, so a substantial number. Especially in the last few years, several larger-scale multi-center trials have been published, both from my own study center as well as two that have been conducted independently. The last published trial was by Wolf, Visser, and colleagues from the Netherlands, and the last randomized controlled trial listed here is from my own laboratory, a non-inferiority trial, which will be completed this year. Now, in terms of the main results of all of these trials, in each instance, ERP or standard CBT approaches were not found to be any more effective than I-CBT. Yet, we do find specific benefits with I-CBT. And in fact, what we found here is that ERP becomes increasingly more difficult to adhere to in the course of treatment. And this downward slope that you see in the graph here was significant. And we see the same with another measure, with level of distress caused by the treatment significantly higher in ERP. There's more distress overall, and it gets worse over time. And yet, this is interesting, no actual difference in treatment endorsement. So even though ERP was experienced as difficult and distressing, people still would recommend it to others. And this was consistent with the fact that we did not find any differences in treatment dropout. But it could very well have implications for treatment refusal. And I don't mean the sort of treatment refusal we measure in trials after people have already accepted to undergo a treatment. I'm talking about those who do not seek treatment at all because of an underlying fear of what is required of them in ERP, fear confrontation. And that's where I-CBT does things differently. These are the treatments then that I will focus on to illustrate how I-CBT fits in or does not fit in with these other models. Exposure and response prevention, going back to the 50s, 1950s and 60s. Appraisal-based CBT starting in the 70s and 80s, and I-CBT after this. First model is the behavioral model. Probably everyone is familiar with it. It basically views OCD from the perspective of a phobic model of development. Compulsions function primarily as avoidant behaviors, which then reinforce the obsession and the anxiety. And in its treatment application, the idea is to break this cycle through exposure and response prevention to reduce this reinforcement. The person is asked to face their fears. And the evidence shows it's an effective approach. It's helped many people, yet at the same time, not everyone. And it's often been argued that the model may miss certain cognitive patterns, not only in OCD, but also in general for other conditions. So the next logical step in the 1970s was to apply a cognitive framework to different psychological conditions. This is the generic cognitive appraisal model. And the basic idea here is that it's not the stimulus or the event that causes the stress, but how the person appraises that event based on underlying beliefs and assumptions that the person holds. And this framework at the time was applied to many different conditions, but when it came to OCD, it took a little bit longer. In particular, it was not immediately clear where to locate or place the occurrence of obsessions in this model. Obsessions are not like neutral or objective events, and thinking of them as an appraisal did not seem to work either. And that's partly because obsessions are so very varied, often experienced as irrational and ego-dystonic. So if obsessions were to be appraisals, then they don't exactly behave as appraisals, not like in other disorders. And I think that's how we arrived at the appraisal model of OCD that we have today, which is basically, at least in my view, an uncomfortable fit with this generic appraisal-based model. This is the model, and in this model, as you can see, obsessions are separated from their appraisals, just like external events are in the generic appraisal model. And this shift was made possible by the idea that obsessions ultimately evolve from normal, neutral events, namely intrusive cognitions. The thought in itself is not a problem, same as the external events are not a problem, but it's the meaning or interpretation given to it that drives the stress and the compulsions. So this is how OCD was made to fit with this generic appraisal model of Beck, Aaron Beck, through the idea of intrusive cognitions. And this model also led to a search for specific OCD-related beliefs in line with Beck's cognitive specificity hypothesis. Things like inflated responsibility, perfectionism, need to control thoughts. But unfortunately, it turned out that these beliefs were not as specific to OCD as was hoped, at least not when measured through self-report questionnaires like the Obsessive Beliefs Questionnaire. Another issue was that this model hasn't shown any clear advances over exposure and response prevention, or ERP. And in its clinical application, it often includes some level of exposure through reality testing, which is part of this model. Perhaps most importantly, the model focuses almost entirely on what happens after the intrusive thoughts, how it is appraised, while neglecting other cognitive processes that may be involved in the generation of obsessional doubts in the first place, before any appraisal occurs. And this then brings us to the inference-based model of OCD, which is illustrated here using the metaphor of an inner and an outer wheel. Most visible symptoms are in the outer wheel, like the emotional reactions, compulsions, and triggers, but also feared consequences, which are a bit like appraisals. So on the surface, what is in the outer wheel here does not seem all that different from the appraisal model of OCD. The real difference is that symptoms here do not start with random intrusive thoughts that then get misinterpreted. Instead, obsessions are seen as doubts or false inferences that arise from a specific kind of distorted reasoning. They're more like conclusions than random intrusions. And these distortions are part of the inner wheel, which in this model represents the cognitive foundation of OCD. It contains three main elements: the obsessional narrative, flawed reasoning processes, and the feared possible self. And it's by working at this foundational level that I-CBT aims to resolve OCD, dismantling the inner structure that gives rise to the obsessive cycle on the outside. This is another way to illustrate the model, more focused on the primary treatment targets of the different therapies. Appraisal-based therapy tends to target the meaning assigned to the thought, steps in after an intrusion has already occurred, reframing the appraisal so that the thought feels less threatening. ERP tends to come in even more after this, further downstream, after obsessional doubt and appraisals have already taken hold. So it focuses primarily on resisting compulsions and managing the emotional fallout, like anxiety and distress. And inference-based CBT aims to intervene before all of this. It focuses directly on the initial doubt itself, as well as the elements in the inner wheel that give rise to the doubt. So it tries to prevent the entire OCD symptom cycle from getting activated. And this is based on the idea that if you dismantle the faulty reasoning behind the obsessional doubt, then there's no need to fight anxiety, manage appraisals, or resist compulsions later on. So those are the basic models. And as we'll spend the rest of this talk on 5 foundational principles of I-CBT, including a little bit on the practical treatment applications of these principles. First principle is that I-CBT views obsessions not as intrusions, but as inferences of doubt or conclusions. Second, it emphasizes the role of narrative. There is a reasoning behind obsessional inferences. Third, it identifies a central reasoning process as responsible for the occurrence of obsessional doubts, a confusion between imagination and reality, or what we call inferential confusion. And then fourth, I-CBT emphasizes the role of feared possible selves, which determine the theme around which a person's obsessional doubt revolves. And finally, the idea that complete resolution of obsessional doubt is possible. There's no accepting obsessional doubts as inevitable occurrences, as if they are intrusions that cannot be avoided. So the first principle, obsessions as false inferences of doubt. If you look on the table on the right, you see examples of different obsessions, and they all include words like maybe, could be, perhaps, or what if. So often obsessions present themselves as something that might be true. And this is another key point in I-CBT. Obsessions typically focus on possibilities, on imagined scenarios, rather than on realities grounded in evidence. And in this context, I-CBT also makes a clear distinction between everyday doubt and obsessional doubt. Everyday doubt is adaptive, it's based in direct sensory information and real uncertainty. And in contrast, obsessional doubt lacks direct evidence. The doubt isn't directly justified by what you can see, hear, or sense. It occurs out of context. It arises when a situation doesn't actually warrant any concern. It's not rooted in real uncertainty. It's not about a real risk that is difficult to assess, but about imagined risks that are treated as if they are real. And obsessional doubt shows persistence. There's a lack of resolution because the doubt was never evidence-based in the first place, not like normal doubts that can be resolved with more information. And finally, obsessional doubts often violate common sense. The person thinks that things are fine, but the imagined possibility or doubt overrules their own personal common sense. So when we understand OCD through I-CBT, we're not really seeing a disorder of uncertainty, but one of artificially created doubt that disconnects the person from reality. And because of this, in terms of its practical application, the identification of the primary obsessional doubt is crucial in I-CBT because it's what sets the entire outer wheel of OCD in motion. And on this slide, you see the outer wheel or cycle of OCD laid out horizontally with examples. In each case, a primary doubt, an initial inference about reality, starts a chain of secondary inferences or appraisals, emotional reactions like anxiety, and compulsive behaviors aimed at resolving the doubt. Yet, without the primary doubt, the OCD cycle would not activate. Several practical applications of this principle. We have exercises to help clients identify their primary doubts. And on the right side of the slide, you see one of the templates that we use for that purpose. Another important technique is condensing multiple doubts into a single overarching doubt. And this gives clients a clearer handle on their symptoms and prevents them from getting overwhelmed by endless variations of the same fear. We also use sequencing exercises. Clients learn to identify their obsessional patterns in real time. The goal is to increase awareness of how quickly doubt arises and also to begin creating a little bit of distance from the process itself. And finally, there are early stage exercises that focus on differentiating everyday normal doubts from obsessional doubts using some of the criteria I discussed earlier. Then the second principle is that obsessional doubt doesn't just appear out of nowhere. It's the result of a narrative and a reasoning process. In I-CBT, we call this the obsessional narrative, and it's the first element in the inner wheel that leads to obsessional doubt. And this narrative combines real-world information with imagined possibilities, creating a believable scenario so that by the time the person reaches the doubt, it feels emotionally convincing, even though the storyline itself is disconnected from reality. So in other words, obsessional doubt is arrived at through a chain of reasoning. It's not random, it's constructed. Here we have two obsessional narratives. I'm not going to read them out here, but what I want to highlight is the structure and the process behind them. In both cases, the person begins with direct perception, either a closed door or clean-looking hands. But instead of stopping there, an obsessional narrative takes over and leads the person to a doubt. In this case, maybe the door did not shut properly, or maybe my hands are still dirty. And this is a key point in I-CBT. The obsession doesn't arise from the stimulus itself, nor from an intrusive thought, nor a single appraisal. It arises from a narrative, a reasoning process that connects what's perceived to what is imagined. So narrative and reasoning acts as a bridge between the stimulus and the obsession. And it's not like the reasoning stops here. It may continue with what might happen if the door is not shut. Like, for example, someone may break in, or in the other example, if my hands are dirty, then I might get ill. ICBT is less interested in what comes after and more in why this initial doubt occurred to begin with, especially when the sensory evidence showed no real problem. Here we have done some practical applications of this second principle. First, we help clients identify the reasons behind their doubts with guided questions and exercises. And usually these reasons are volunteered quite spontaneously, simply by asking the person, for example, why do you think your hands are contaminated, or why do you think the door might be left unlocked? And then with the reasons and justifications of the doubt identified, clients then write out their full obsessional narrative, showing how their narrative builds towards doubt through structured reasoning. And this is what we call then the narrative unit in ICBT, not a single isolated belief, but something a lot more dynamic and fluid, a story. And with that narrative or story identified, they will then also begin creating non-obsessional narratives and ask to engage with this new narrative to begin creating some distance from the obsessional narrative. Which brings us to the third principle, which is that obsessional stories lead to a confusion between imagination and reality, where hypothetical possibilities and scenarios are mistaken for real-world probabilities, or what we call inferential confusion. And according to ICBT, this confusion is the outcome of distorted reasoning and imaginative processes that are embedded in the obsessional narrative. So it's not the content of the obsessional narrative, like beliefs, standards, or values that lead to inferential confusion. It's a distinct reasoning process by which imagined possibilities are treated as if they are real concerns. And I'll break this down further because this principle is really the essence of I-CBT. This is how perception and imagination operate normally. Perception provides real-world sensory information, and imagination generates limitless possibilities. And when working together, they generate reality-based probabilities. So, for example, if I hear a noise in the middle of the night, a number of possibilities might go through my mind. It might be my partner walking through the room, a hanger may have fallen in the closet, or perhaps if I'm anxious, I might think it could be an intruder. Whatever scenarios I come up with, these are all probabilities grounded in direct perception, and they support non-obsessional reasoning. So it's imagination working in tandem with perception. In OCD, this natural interaction between imagination and perception breaks down, as shown here. Perception is still accurate, but imagination starts to operate without a perceptual anchor. So doubts in these instances arise purely from imagined possibilities, not from reality. And that is what makes them obsessional. We're no longer dealing with valid, relevant possibilities or probabilities. They do not have any basis in sense information anymore. That's not all, though. OCD goes further. It also creates a false overlap between imagination and perception, making it seem as if perception and imagination is actually working together, even though they are in reality entirely disconnected. And OCD hides this superimposition of imagination on reality, basically creating a cognitive illusion through a sleight of mind. And again, this does not happen spontaneously, but as the result of obsessional reasoning that produces this illusionary overlap, which in practice we refer to often as the tricks, the reasoning tricks of the OCD. We've categorized these reasoning tricks into three principal components, which can be further subdivided into another three, but they all lead up to the primary doubt and a state of inferential confusion. The first of these is a distrust of the senses and self, which refers to the active dismissal of direct experience coming through the senses. The second component is unchecked imagination, which revolves around the generation of limitless possibilities once sensory trust has been breached through the first component. And the third component consists of the misapplication of reality-based information, where facts, values, and real experience are selectively applied to support an imagined threat, giving it a semblance of reality, even though it's not. And together, as part of the obsessional narrative, these distortions create obsessional doubt, leading purely imaginary possibilities to be confused with a probability relevant in the here and now. And still does not end here in terms of the OCD cycle. Inferential confusion also creates a lived experience of doubt. Because once the doubt has taken hold and taken to be a real probability, this can produce what we call phantom sensations and experiences through a further deepening of imaginal absorption into the doubt. So, for example, in contamination-related obsessions, someone may experience a burning or sticky sensation on their skin after touching a doorknob, despite no actual contaminant being present. Or in sexual or moral obsessions, a person might experience an unexpected groinal reaction as a result of immersion into the doubt. And this is then interpreted or misread as confirmation of the doubt by reversing causal direction, which is a distorted reasoning process that completes this entire cycle. So these phantom sensations are in reality the outcome or consequence of the doubt, but OCD then turns this around as evidence for it. So the person is trapped from both ends. In terms of the practical applications of this, we try to unravel this cycle for clients, which is grounded in insight and realization, not in debating or challenging the content of obsessional doubts. Instead, the goal is to recognize OCD as a con artist or illusionist, not just as a metaphor, but quite literally by seeing through the distortions of OCD. And one of the ways we do this is by analyzing obsessional narratives to identify these distortions and applying insight into how they lead to doubts that are imaginary, irrelevant, and false. Then the final and third element of the inner wheel is the feared possible self, which is defined as a fear of who one might be or might become. And this fits well with, it's a concept that fits well with I-CBT because it's essentially a self-doubt, a might be. And in the slide on the right, you can see all manner of feared possible selves. None of these are considered unique to OCD in terms of their content. So it's not like any of them is specific to OCD, but from an I-CBT perspective, if it is an obsessional feared self, then it's created by the same reasoning distortions as obsessional doubt. So it's a false and unreal self, and in terms of its practical application, the goal is to invalidate this feared self and bring the person back to their authentic and real self. This is in the same way as we try to get the person to stay out of their obsessional narrative. And in terms of the overall effect of the feared self, ripples through every aspect of OCD. It moves through the narrative and ultimately shapes the specific obsessional doubt that the person experiences, which is always personally meaningful. And to see how this fits into the larger structure, it helps to think of the inner wheel as a layered system, as shown in the image. At the center, there's the OCD trifecta, a breakdown in reasoning that includes this distrust of the senses, imagination, and misapplied reality-based information. And surrounding this then is the feared possible self, an identity that's constructed by these distortions. And the obsessional narratives then build around this feared self, reinforcing it, embedding it more deeply, and setting the stage for specific doubts to surface as the outcome of this entire layered structure in the inner wheel of the OCD. So important to keep in mind that the presence of a feared possible self alone is not unique to OCD. They are part of many different conditions. The difference in OCD is that that it is an obsessional feared self. And what makes the feared self obsessional is because it's constructed through the reasoning and imaginative distortions of the OCD trifecta. Shown in the diagram here, it are the reasoning, these reasoning and imaginative distortions that turn existing vulnerabilities and insecurities into an obsessional feared self. So, for example, a new parent might feel insecure about their abilities as a parent. This is entirely normal. But when OCD gets a hold of that insecurity, it is able to turn that into a real identity crisis through the distortions of the OCD trifecta. So in a similar way, as when we ask what makes a doubt an obsessional doubt, as opposed to something else, we can do the same thing when it comes to the feared self. It's always a question on how it is created, not necessarily its specific content. And this differentiates obsessional feared self from those we see in other disorders. I won't stay long on this slide, but the main point is that they arise through different processes. Non-obsessional feared selves tend to develop through more typical emotional and cognitive pathways shaped by experience, self-reflection, and mood. And in contrast, the obsessional feared self emerges through the distorted reasoning I discussed earlier. It's less of a core belief and more of a manufactured identity crisis. And this has important clinical applications. For example, treating an obsessional feared self as if it were a core belief using traditional cognitive restructuring may not be effective here. Instead, I-CBT approaches it in the same way as it addresses obsessional doubt by targeting these reasoning distortions that created it in the first place. So the goal is not to restructure a belief, but to dismantle an illusion, which is what the feared self is. And finally, the fifth principle, and the most hopeful one, I think, which is that obsessional doubt can be fully resolved. And once obsessional doubts are resolved, then this would also result in a complete remission of symptoms. And this is possible conceptually because obsessional doubts are not random or inevitable in I-CBT. They're conclusions drawn from a reasoning process that detaches the person from present reality. So in this model, OCD is like a mental bubble. This is a metaphor we often use. And like any bubble, it can be burst when it's seen for what it really is. In practice then, the principal goal is for clients to gain the insight necessary to resolve the doubt. And this insight comes down to the realization that obsessional doubt does not really need resolving, given how it is generated on an illegitimate basis. It's not a relevant concern, and in fact, it should not even have occurred to begin with. And once that insight is established, at least to a degree, clients are also encouraged to act from this knowledge, not just behaviorally, but cognitively as well. And that means the focus is on not trying to reason one's way out of the OCD. It's about not reasoning your way into it. Also, and this is near the end of treatment, there are exercises we teach that we call reality sensing, which consists of acting without doubt or anxiety. So it's a way of putting insight into action when knowing and doing are fully aligned. And that brings me to the last point of this talk, which is how reality sensing relates to exposure in ERP. And one important difference is that in ERP, the typical sequence is to start with action, to face the fear head on, right? And then over time, the idea is that insight or change in belief may follow because of that. In I-CBT, that sequence is reversed. So behavior follows insight. We begin by helping the client see clearly that a doubt is based on a faulty reasoning process, and then we act from that understanding. And this is also why reality sensing is not exposure. The person is not confronting anything because it begins with the idea that the obsession is false and incorrect. So while the same actions or exercises on the surface may seem to be similar, they are entirely different. For example, when you touch a doorknob or walk away from a stove, the intent behind the action and the context in I-CBT is entirely different. In reality sensing, the action comes because the person already knows there is nothing to fear. It's not a test. It's just a return to what is already known through perception and common sense. So this diagram then brings everything together, captures the full structure of OCD as a self-reinforcing system. Principal point here is that everything we discussed so far, the reasoning distortions, the feared self, obsessional narratives, doubt, emotion, and compulsion, they're all components of a larger loop driven by inferential confusion, confusion between imagination and reality. So the inner wheel sets the stage and the outer wheel plays it out, and together they create this immersive cognitive space that keeps OCD alive. This brings me to the end of the talk. If you want to know more, I've recently completed a 2-volume series on I-CBT to replace the old manual from 15 years ago. It's both for professionals as the general public, and all of the concepts in this talk are described in detail in this book, including the diagrams, and with the addition of a lot of practical tools in applying I-CBT, either with or without a therapist. There's also extensive scientific literature base supporting the approach, with more than 100 scientific publications at this point. And I'll refer you to the website I-CBT Online for a list of these publications. It's also where you can find a lot of free resources and videos created through these meetings here to help you further if you're interested in learning more. And of course, we have our Facebook group with more than 4,000 mental health professionals right now, where I would encourage you to ask as many questions as possible in that group. Many people are happy to answer. And if you really want to learn I-CBT, it requires a lot of immersion into the approach. And asking questions is one of the best ways of doing so. And finally, happy to announce that also I'll be providing a new and expanded I-CBT training and workshop based on the new series coming this year. Thank you.
Thank you, Fred. My new favorite quote, the goal is not to restructure a belief, but to dismantle an illusion. I love that. That was great.
Right.
Great.
Okay. I open the floor for questions.
I have a question.
Yeah, go ahead.
Okay. Yeah, so yeah, thanks for the talk, Fred, and I appreciate everything you've done. With I-CBT, I'm super interested. One of the questions that I have is, this concept that the obsessional doubt is not necessarily connected to the content. It's more the reasoning process that led to it that makes it obsessional. Are there times where the possibility is actually much higher or even probable in an obsessional doubt, but it's still obsessional because the reasoning process was, obsessional. The reasoning process itself was distorted, and so that led to this doubt, even if the doubt has a high probability of being true.
Well, I mean, yes, there are variations in whether things are probable or not in terms of likelihood, right? You're talking about likelihood. So sometimes
Right.
sometimes things may be more likely, but I-CBT is focused on showing the irrelevancy of the conclusions or inferences or doubts that go through our mind to the here and now, So it doesn't really play into OCD at all. It's an entirely separate dimension that makes no difference. When a thought, like for example, it may be more likely that my ceiling will come down versus that I might get hit by a meteor right now, right? So likelihood and probability is higher, but in both cases they're still irrelevant because uh, no meteors were predicted to come down, nor do I have any cracks in the ceiling, right? So it has nothing to do with that from that perspective. So it's a process that operates entirely independent from probability in that sense.
Yeah, that's helpful. Yeah, I think that's one of the things I think I get sort of caught up in when I'm working with clients is that, like, but this feels really like it's probable, right? Like I could make a mistake here and buy the wrong pair of shoes because I could do more research on this. But
Yeah.
it's like you said, yeah, go ahead.
It's not, it's just, it's ICBT looks at the irrelevance of how the person arrives at these doubts to start with, and whether something is, the probability doesn't come into play anymore because the thought should not have even occurred, as it normally doesn't either, in other areas of the person's life.
Right.
So, yeah, does it, is that clear? You
Yeah,
have
yeah,
to get,
that's clear.
I think when you get into discussions about probability with clients, then usually that fundamental underlying process has been forgotten. You're debating something else at that point. You're almost like in a GAD type of model. By saying, well, how likely is this really? Maybe this is not really likely. The problem with OCD is that it doesn't care about likelihood at all. It does not care. So you don't get very far with that argument, by saying, well, this is not very likely, or this is more likely than something else, because OCD only needs the slightest margin of possibility to
Mm.
survive, exactly because it confuses with something. It makes it relevant, even though it's not.
Can it, yeah, in the book, you talk about the five questions to ask, common sense, is it in context, is it resolvable? Can it have one of those things and like, four of them, it kind of hits the mark for obsessional, but one of them, let's say like it could be in context, and would it still be obsessional?
Well, I think they all have to come together, and they all have to be. It's basically a technique to be able to tell the difference in how obsessional doubts tend to manifest in comparison to everyday doubts that we all experience. It's not meant to automatically resolve the doubt. And I think you have to be careful in the exercises and in the resolving OCD series. It's also explicitly warned against. Do not say like, okay, once we have these answers, so therefore it's an obsessional doubt, and now we have it resolved. It. No, no, that it doesn't go that quickly. And trying to approach the exercise like that by answering the questions as long as an obsessional doubt, okay, now you should drop it, you're probably going to make it sort of a compulsive questioning to start with, right? So you want to be careful with that. Uh, OCD is more complicated than just being able to answer these questions, which goes deeper into the process. As we see, for example, in the Resolving OCD series, we go far more deeper into what makes something obsessional versus something else, which is the very specific reasoning and imaginative distortions, which we
Mm.
call the OCD trifecta or the superfactor, where it goes even further than that, as you showed in the graphs. So that's in chapter 6 of Resolving OCD. So when it comes to resolving OCD, you have to be careful, I think, not to start too soon with that, because resolving OCD
Mm.
ultimately means coming to an insight that there is nothing to resolve. So OCD is quite paradoxical in that sense.
Yeah, yeah, thank you. Yeah, appreciate it.
Okay, Andres has his hand up.
Yeah, one question. I'm very impressed about how I-CBT works with my OCD patients. But my question is, in your opinion, what's the importance of the learning history of the patients? As I read, when I read the books, it's non-biographic. So the people are interested. What's the reason? Why can't I trust my senses, for example? You know
What do you
what?
mean? What do you mean with learning history of the patient?
Uh, what have I learned in childhood, at home, at school, etc. Yeah, then there must be a reason why.
Oh, okay. Yeah, yeah,
Yeah,
yeah. Well, I
you
mean,
understand?
we try to stay close to the person's experience, right? So
And
when
we
we
hear,
ask when we ask about the narrative, we ask them like, okay, what do you think justifies this particular doubt in the here and now?
yeah,
And that can sometimes history may come in there. But we do try to be careful not to say like, okay, when we try to identify the narrative and the reasons for the obsessional doubt, it's not like we're going to look for the ultimate cause of the OCD. You want to know what justifications you have and what reasons you have to consider this doubt to be a relevant thing in your life, why this doubt is real to you. And I think you have to be careful a little bit with digging in the past to the extent it's okay. The past can definitely be part of a justification for an obsessional doubt, but it's something different than looking for some past event that may be the ultimate cause of the doubt. And that I think you have to be careful with, even though that may have played a role, but I would not address that in the beginning. I would address that later on, maybe as part of the fit possible self or the vulnerable self theme, even more so. Why do you have insecurities in that area of your life? But no, those things don't necessarily, or not necessarily, usually they don't explain OCD from a causal perspective. A person with a certain history that may be traumatic or whatever else it may be, they don't automatically always develop OCD. It could be anything else, right? So these are fairly non-specific factors when it comes to OCD. That's why I-CBT would always be primarily focused on the reasoning and imaginative distortions that are specific to OCD, or at least have shown specificity. Not to say that you cannot bring these other factors in order to better understand the overall picture, but not as a way to try to resolve the doubt necessarily.
Thank you.
All right. There's a question in the chat. Sylvie's asking, could you clarify if resolving OCD means that OCD doubts will never occur again, or if OCD doubts will still arise, but they could be easily dismissed, similar to how non-OCD sufferers dismiss any irrelevant thought that arises in the stream of consciousness?
Yeah, no, resolving OCD means that it's not just like, oh, now I have this thought and I'm able to dismiss it. May start with that, right? But ultimately, if an obsessional doubt and you see it has no basis, then ultimately it should not even occur anymore, And clinically, that is something that does happen. Not just in I-CBT, I'm pretty sure it happens in ERP as well. If it's highly successful, that a person says, well, I don't have this thought anymore, doesn't make any sense to me anymore. It's just gone. That's it. That's the end of it. Now, not saying that always happens, because our therapies are not always that effective, right? But truly resolving OCD to the extent that a person basically has completely recovered, that would, to me, include the fact that it barely or not at all occurs anymore. It can sometimes occur, but that's something different that occurs out of habit, right? Even years after, a person may sort of like be in a situation that reminds them of the OCD they had, and then maybe a thought may pop up, but that's not the same thing as a doubt anymore. It's the same as when you stop smoking 10 years later, still sometimes occurs, But that I would not consider to be inconsistent with the idea of resolving OCD. Was that clear? I don't know who asked the question, but
It was me. Yes, thank you. It's very clear. Thank you.
okay. Oh, Sylvie, okay, thank you.
Susan, do you want to ask your question? I'm not quite sure what you're asking. You're muted, Susan.
Sorry. Does that when treatment's effective, I was wondering if there are any studies that show, particularly with ERP, if that lasts, the disappearance, let's say, of obsessional doubt. Is that
yeah? If we empirically, if that's investigated, we don't sort of like qualitatively investigate it in that way. So ask the question like, does it really disappear? But it would be operationalized in terms of your Weibuck score, for example, the score that you have, and does that last? Yeah, and if the person really goes into remission and into recovery being defined of being 1 year in remission, according to a particular cutoff score point that people use in the Y-box, the literature has shown that these gains are quite often maintained longer term. So Maybe your question is, do you have OCD for life automatically? No, I don't believe so. You know, I do think you can get rid of it. You know, within the limitations that we have as therapists, and within the limitations of the therapies that we offer. You know, but there are people, fortunately, that are able to do that, and I don't consider it to be impossible. No.
Yeah. Thank you.
Me either.
Mhm.
All right. Okay. So we have another question. I've heard before that the FPS, the fear of possible self, is kind of the greatest of all the doubts, and that many obsessional doubts stem from this core false self. Thoughts on this?
No, it's not. It's not. It's not the basis of. It sort of runs through the narrative automatically. But what is the basis as obsessional doubt, or what is the basis of OCD? Is, as I discussed in the presentation, are these cognitive distortions, these reasoning and imaginative distortions. You know, they are at the basis of the obsessional feared self forming, which in turn embeds itself in the narrative, or the narratives form around that, which in turn logically lead up to the obsessional doubt. So it's just one aspect. It's the self-related aspects of the narrative in the of the obsessional narrative. But the basis of OCD lies in these imaginative distortions and these reasoning distortions. Those are specific to OCD. I mean, I think you're on shaky ground empirically and theoretically to start claiming that that feared selves somehow are the foundation of OCD, because speak to a person who's depressed and you say, I'm worried and afraid of being worthless. You know, oh, there you go. I mean, how you cannot really claim that feared selves are specific to OCD, no matter what their content is. You know, so no, it's not at the basis of obsessional doubt. It may be at the basis of a lot of psychological conditions and problems, but not specific to OCD. You know, so that's why we focus on these aspects that are more specific to OCD. But the feared possible self is a powerful concept as long as you consider it to be as part of being produced by these imaginative distortions. That is what makes it obsessional. So it can still be a powerful concept if the person gets the idea. Okay, this is an illusion that's created by the same distortions as my obsessional doubt. So in that sense, I think the concept can be very helpful and powerful within treatment.
I'm glad to get
Is that
clarity on that as well, because I've confused that myself in the past.
we
Okay.
actually have some, there's a paper coming out soon, and we have some evidence for that now, how that works. It's through inference and confusion, or through these distortions, that the feared self emerges, or at least is linked with the occurrence of obsessional doubt. You know, so it doesn't start with just the fear of who you are, that then you have OCD. No, OCD has to hook into a specific vulnerability first, and it has to hook into it in an OCD type of way, you know, in order for it to lead to obsessional doubt.
Nice. Okay, guys, we have about 5 minutes. Don't know when you're going to have ask the expert again in the near future anyways. Are there any burning questions people have about I-CBT, about the presentation?
I have a question.
Go ahead.
Yeah, I feel like it's been asked before, so I'm sure you might be a little tired of
I
hearing.
don't mind. I don't mind.
But I still get stuck on what to actually tell people or help people with. And that's people who really get stuck. You had said earlier that some of the components were secondary doubt and emotional reaction, and then compulsion that people tend to do. And it's the emotional reaction, I feel like, that a certain percentage of people that I work with, maybe it pulls them more than others. So when they have that kind of whoosh feeling, right, or that feeling inside that it is it is start beginning that inferential confusion, I think is ultimately a part of it. But they're more susceptible to that feeling true. And I know it's addressed with the thinking kind of errors, but I didn't know if there's anything else I can do to help people who are really stuck on this. If it feels this way, then it must be true.
Right. It's not, I-CBT is not an intellectual approach in that sense, where it does not would not sort of see these things as sort of secondary. But I think it's important to realize that this emotional intensity is part of the narrative. It's not a dry reasoning that a person leads the person to an obsessional doubt. No, it's emotionally very charged through the narrative, which has a lot of emotion in it already, you know. So when we talk about emotion, are we talking about emotion that comes, or anxiety that comes after the obsessional doubt to some extent, but it's also already emotional charge because of this whole story behind it. And it actually infuses the obsessional doubt with this intensity and emotion. And unfortunately, that's something we don't investigate that much, the intensity of obsessions. We talk about frequency, we talk about all these things, and how the person reacts to necessity the person feels to act upon it, but we don't talk much about the intensity of obsessional doubt. And I think that's the crux of the issue, not so much the anxiety that comes after. I mean, yes, some people may have a GAD in combination with OCD, or they may react more strongly and have more of an emotional or anxious reaction in general, you know. But I mean, I think the real problem starts before that already, where when you're dealing with OCD at least, where the obsessional doubt is extremely intense and emotionally charged. So then the question is, okay, how do you deal with that? Now, you have to slow down the process for the person to get back to where does this doubt come from? What is the moment that I cross over from imagination into reality? At what point do I lose my grounding in reality? You know, and that requires time, and requires for some people a lot of work. You know, so it's not automatically like you're going to say, the person may say, "Yeah, okay, I realize it's in my imagination." If that's just an intellectual understanding, it's important not to get stuck on that, because I-CBT is about more than that. It's not a dry intellectual approach where I explain to you now you know it's imagined, so why do you still have issues? That's not how it works, right? So you have to see, like, okay, why does the OCD still trick you into this? Why do you still have this story that infuses the doubt with so much intensity? And that's not a simple process, but I have tried to break that down increasingly as compared to the older modules, and like structured steps for the person to gain more control over this process of where they get lost into the bubble, including more tracking. Some people get it. Some people, when they see, like, okay, when they find it, for some people it's more sudden, where suddenly they resolve the OCD by seeing, yes, it's imagined, it's not real anymore. Others require more work, you know, and I try to focus that on those people a lot as well in the especially in the second volume or in the later chapters, to give them more structured exercises to do, to reach the same point of as those that find that resolution earlier. And why that difference exists, we don't know, you know, or I don't know. Where some people suddenly, it's not like one person is smarter than the other. It's also not a matter of severity necessarily. So, but we need to address both these groups of people in order to have the largest amount of proportion of people benefiting from the treatment. So.
Yeah. Right. Thank
So
you.
as we're wrapping up, Fred, thank you. Melissa, and I really love the fact that you say this has probably been asked before. I'm sure a lot of people think that and think, oh, I'm just going to bore everybody, but there's never any dumb question in I-CBT. As we learn, we grow, and other people are looking for the same answers. But Fred, people have asked about your training, when you anticipate it will be, how will you be advertising it? They don't want to miss And so maybe we'll put a plug in for that before we wrap up.
Sure. But I have no set date yet, but I'll definitely announce it in the Facebook group and on I-CBT online. And it will initially be probably a 3-hour training, and then later we'll extend it to 1 day, and who knows, maybe even longer. But right now it will be this year, you know. No set date yet, but I'll announce it in the Facebook group.
Terrific. Well, thank you so much for sharing your knowledge and expertise in your work with us. Thank you everyone for who attended.
Thank you, Margaret, and I thank you for all the volunteers and everybody who's involved in everything we do in the Facebook group.
All right. Y'all have a good weekend.